Well, welcome everyone to our annual meeting 2023 of the PA Clinical Network. It's been a while since we've been face-to-face, and a pleasure to see those here in the room, and also a pleasure for those that have joined us online. Sincere appreciation for spending your time with us this evening. We have a full agenda, and we do treasure your time, so we want to get through with that. You will hear from many of our partners tonight. Our principal sponsor this evening, go ahead. Oh, I have that. Oh, there we go. Sorry about that. That's me, John Pagan, your chair and CEO. And our principal sponsor tonight is Curi, and also special thanks to LabCorp for sponsoring the social prior to this meeting. You will be hearing from both Curi and LabCorp later on. Again, we have a full agenda and some wonderful speakers lined up. Please hold your questions to the end of each presentation segment. As you know, this meeting is being recorded. Please do not make any recordings on your own. We are in a competitive business, and we only want to share our business with our friends together. Please reach out to Keith Taylor or any of us if you need any more information about any of the presentations. Our keynote speaker this evening is Dr. Wilson Jackson, who is president of the Pennsylvania Medical Society. Dr. Jackson and I go back a long ways, and I'm honored to have him as a colleague and a friend and your advocate at PA Med. Dr. Jackson and his group, Jackson Siegelbaum GI, are also part of the PA Clinical Network. Dr. Jackson?
Thank you, John. And again, John was a terrific friend, mentor, and colleague, and just kind of someone I admired very early in my time with Pennsylvania Medical Society, boy, going back now quite a few years. And I appreciate his support throughout. Anyways, I apologize to a couple of y'all. Some of you guys have probably seen some of these slides before. I'm going to try and move through this somewhat swiftly. I feel like I'm preaching to the choir to some extent, because some of this information is some we either know intuitively or know very, very well. But primarily, my goal for the year as president has been to try to increase awareness around the cost of care, the quality of care, where physicians fit into that whole continuum. And part of that message has been, I think physicians need to step forward and become even bigger leaders, and the people in the room and online have been certainly part of that message. So data that we already know, healthcare expenditures are exploding all over the place, no matter where you look. National health expenditures, Medicare, Medicaid, private health insurance, out-of-pocket expenditures, all rising at a rapid clip, and that's not new information. This has been going on for years. And if we look nationally across the country, this is the slope of the curve as it adjusts for 2020 dollars, and there's been a steady rise going back to the 1970s. So we all know this data. We all realize that the cost of care has been rising. And you look at Pennsylvania specific data, what you'll see is we represent a pretty good chunk of that total dollar spend there. And that's been steady rise. And so this graph largely falls in line in parallel with the national curve. So Pennsylvania is right in line with what's happening nationally. When you look at Pennsylvania specific data, I mean, where are we spending the money? Again, you look at a pie chart, and largely the hospital systems here and physician services make up the big chunk of this. Nursing homes, dental, medical durables, home health, make a smaller part. But this is where the money is being spent. Again, this is Pennsylvania specific data. And again, this is largely can be laid upon what's going on nationally. When you look at health expenditures and where that money is coming from, largely it's taxpayers. It's the people, the communities, people throughout the state that are writing the checks one way or the other to subsidize and provide and afford to make the healthcare affordable. Big chunk of this is the federal government, households, individual expenditures, private business sector makes a big chunk of all this. But by and large, it's taxpayers who are underwriting this bill. So my kind of themes, if you will, has been competition has been squeezed out of the marketplace in healthcare. And I think we need to reintroduce competition, and the clinical network here is really going to be a critical part of doing that and bringing that to the state of Pennsylvania. So we are the network here is in a really unique position to drive that quality message. So where are we in this whole network, this ecosystem of healthcare? And I stole this from a Professor Burns who spoke at our PA Med board meeting back in March. And he calls it the healthcare ecosystem. And if you look at where all the different players in this, and we got the pharmaceutical companies, got physician organizations, got government up here, health plans, hospital systems, then you get all these other players. And the system is so intertwined. But when you try and look at where do you tease out, where are the two critical parts of this whole large morass, and the patients up, or the physicians over here and the patients over here, we got all this stuff going on between the two. It is a system we have, and it's not necessarily one single fix is going to resolve this, but I think we need to keep this in mind as we navigate our way through healthcare and other changes. And this is the changes when you look at our economy going back to the 1950s, and the healthcare is an enlarging sector of the total health expenditures throughout our economy. We're probably right now around 17% of our GDP. We're probably moving up to about 20% within a few years. So what has happened over those years? And in my perspective, a lot of it has been consolidation healthcare. And the question then is asked is how has that consolidation impacted the cost of care and the quality of care? And I'm going to run through a little bit of data, but I'm going to try to kind of move through this swiftly and just kind of stay at a relatively high level, but I'm happy to dig into the background that leads to some of these conclusions. Healthcare, the IDNs, and these goes by a couple of different monikers, but integrated health network systems are largely hospital-centric, and some have an insurance product coupled with their healthcare delivery system. So they're not just a provider, but they're also the payer of the system. And we have some of those in our own state. The FTC has had a limited ability to impact this consolidation that has happened. And that's really the only significant governing body that has jurisdiction over this consolidation. At the state level, attorney generals, Department of Justice to some extent, but by and large, these mergers and acquisitions have been happening with largely an unchecked process. So this is looking at data going back to the 1950s and hospital systems that are coming together, and there's just been a steady rise. And this is nothing we don't already know, and it's happened in our own community and throughout the state and the country. But what about the health systems and how big they have become? And these are systems within a certain region. And what's happening now is they're expanding across the national footprint. So you look at some of these really massive systems, and Pinnacle here, UPMC and Pinnacle is on this list here. And this is going around the nation about some of these really mega systems that dominating these marketplaces. Admittedly, delivering good care, but I think we need to pull back the covers a little bit and look at the cost of that care to being delivered. So this is how the system works. And we all, again, know how these things come together. You have an IDN that becomes the hub, and they tack on physician practices, surgical specialties, hospitals, ASCs, and they full spectrum of the continuum of care from nursing homes, durable medical equipment goods, infusion centers, home and other home therapies, physical therapies. So they become a kind of a one-shop process. And then some of these also have an insurance product tacked on there. So from my perspective, this consolidation has decreased competition at the same time, concentrates the market power and has driven up the cost. They just wield huge amounts of clout in their negotiations with the commercial payers. And this is just to kind of, this is a composite slide that looks at within a market consolidation, and that's it. We'll just use Harrisburg as an example. We've seen the consolidation in Harrisburg over the recent years. It's happened in Pittsburgh, rural parts of our state, and other parts. But when you look at the cost, the price increases on average go up to 20 to 40% for the same services being rendered once a market becomes more consolidated. In other areas, there's a larger price for impacts when mergers hospitals come together, they realign. When you look at what they call cross market, say Pittsburgh and Harrisburg, for example, it's a cross market. In other words, the zip codes are different, but the consolidation of the market, they have one negotiating power. And again, you see an increasing rise. This is more recent data because this is a newer phenomenon. But I'm thinking 5 years from now, as these health systems become even larger, there's going to be perhaps even a further rise in the cost of care as these markets consolidate. There's more data behind that, and I didn't left out here, absent from this, is when you look at what's happening in our state, is we have Kaiser Permanente coming in, taking over a large health system, and that's an example of a cross-market consolidation. We can talk about that later. I'd be curious as some people's thoughts are around that. So what about the quality? And this is some article that I published just earlier this year out of JAMA. And most physicians, we know this, most physicians, about 50% are part of a large health system. There's a huge amounts of variation in the size, and the commercial prices paid for the cost of care has been gone steadily up as these big systems get even bigger. This is a composite table from this data, but the point here is the average spend amongst the commercial and Medicare beneficiaries. And this was a unique study because the researchers, it was done out of the public health department at Harvard, coupled with some similar people and researchers in University of Alabama. And they looked at not just Medicare data, which we can get a hold of, but they also were able to get, using tax ID information, they were able to get and look at the commercial payer data. So they were able to pull it together, which is a really unique ability to pull that data together. And the bottom line was there was about a 5% increase spending amongst non-system patients compared to those in consolidated systems. So when you look at, when this is a comparative study, they looked at cost of care in those areas where there's consolidation and those areas where there's not consolidation. They teased out hospitals that were part of a larger network and those that were part of a larger network. And the larger network hospital on average had a 5% higher spend for same services rendered. So the market comes consolidated. At a minimum, you're looking at a 5% increased cost. So the bottom line, this is out of this article here, was large health systems, small quality improvement at substantially higher cost. Same care being delivered, same patient care being delivered, but at the same time, there was an increase of the cost. So this is another study that came out of New England Journal about almost 3 years ago now. And this just has looked at the changes in the quality of care. So we looked at cost. Cost we know goes up based on the data there. But what about the quality of the care goes up? And this is a interesting study, and I'm going to skip over for the sake of time, but they looked at 4 broad categories. They looked at patient experience, 30-day readmission rates, clinical process composite, and 30-day mortality. Pretty kind of basic fundamental research. And they looked at what happens before and after a merger and acquisition event. So you can look at this slide deck later if you like, but this is time 0. So this is 3, 2, 1 years before, 1, 2, 3 years after these events. And what happened to these different 4 benchmarks? And what happened was once they the patient experience was not improved, and there was no changes in mortality or readmission rates, and there was the process improvement were somewhat inconclusive. So at the bottom line of the study out of JAMA, again, a pretty comprehensive study around the country, was there's higher quality, lower prices where we really need to go and try and get to. So how do we get there? How do we improve that quality of care? And this network, this very group here is in a unique position to do so because primarily it's physician-led. And that's where I think we can make a big voice and a big impact on trying to bend this cost curve. So all payers want to reduce costs. We know that. That's what their goal is. And then I think as physicians, we can help maintain that conversation in a way that reduces the cost of care, and specifically reducing ED visits, reducing hospitalizations, and all the preventative care measures there. And we can try, the network can also bring back some degree of competition into the marketplace. You know, these consolidated health systems where the physicians and the whole healthcare team is part of an employed network, there's less competition for quality of care, much less the cost of care. And I think a united front behind the clinical network here enables us to maintain a more competitive edge and hopefully level the playing field somewhat. So doing so through the network, there's been able to do some data analytics, administrative support, and of course the GPO option as well that many practices have been able to leverage. So this is where the network has been able to try to kind of broker all these different relationships, all these different payers, which is really unique for a clinically integrated network. I'm peripherally involved in one of the other clinically integrated network, at least kind of aware of it. And, you know, they are limited based on, they're centered around one of the health systems. They're limited by their health system and the relationships and the dynamics of their marketplace. This clinically integrated network at Pennsylvania Medical Society has the ability to kind of contact all these different payers, which is really unique and a unique model around the country. So we know how, and the physicians know how competition works in healthcare, and we know how to reduce the cost. So we can be, through the network, we can be part of that conversation. So this is where I'm going to give my little blurb advertisement, and apologize for those who have heard this before. So we looked at some data where physicians are in the leadership roles around the country. And this is a study done, I think it was coming out of JAMA, no, I'm sorry, General Internal Medicine. And they looked at who are the board of directors around the countries of the 25 largest health systems in our nation. And These are the really big mega systems, big consolidated systems. And who's on the board of directors? Who's really calling the shots, so to speak, with mergers, acquisitions, negotiations? We know the CEO is sort of the face and the lead of these organizations, but it's really the board of directors that wields the ultimate authority over these health systems. And I'll add, many of these are nonprofit health systems. That's a different conversation we can talk about later. But who are these people? What's the skill set of the board of directors? And if you look at primarily, the bulk of them are actually in financial activities. You know, they're investment bankers, they're people with experience in mergers, acquisitions, private equity. So those are financial activities. Another big system is the legal component. Informatics, trade information, utilities, resources, and mining make up a chunk. But if you look at all the skill sets of the board of directors around the countries in the 25 largest health systems, 16% have healthcare experience. And this particular study clumped in nurses and physicians together. 16% of our nation's board of directors are physicians. I would venture that we need to have more physicians at that table making those discussions and decisions. What about Pennsylvania? This is Pennsylvania. I was only able to pull out 5 different of our health systems here. And of all the board of directors of these 5 health systems here, 24 are physicians, 24 out of all of them. And that's, again, about a 15% are physicians in our leadership positions of our large health systems in our state. So how do we get to where we need to be? And I think physicians need to be engaged. They need to step up. They need to recognize the cost of care is rising. They need to recognize that competition in the environment is decreasing. And I think they need to kind of be part of the voice about kind of what has happened in a consolidated marketplace. So this is kind of what I'm hoping to kind of accomplish going forward. You know, shout out to Marty, who's been a big part of kind of championing this. But we're hopefully to build we have a year 1 curriculum. We're hoping to build on that, a year 2 curriculum for physicians to take and learn some of the skill sets that focus really on kind of the healthcare mega mergers that's happening out there and how they can better understand the dynamic of the healthcare and where the physician's voice fits in all that. So I'm happy to take any questions. I hope I stay within a rough time allotment. I know I've burned through a lot of that quickly and happy to take any questions there. Yeah. Yeah.
The state healthcare, the state cut. There was long care was the second part of healthcare. It never happened. And the hospitals there are limited.
Yeah.
You have to get approval open in the hospital, so you wouldn't have seen 10 state open hospital right across from you can see. And when they buy hospitals, they can't just rate. And as partners, it's now Mass General Brigham. They don't make money, so they don't have a $2 billion profit. And you know, it's so frustrating because basically, as a private practitioner, the insurance, the 500 contract might be 146 Medicare. And the hospital, and what I need from this organization, I really need some help negotiating with payers. And we have no leverage.
Yeah.
So even if we're providing good care, it just keeps getting kind of cut back. And what ends up happening for me as a 61-year-old is I'm not going to be able to pay this. And that's really where we're at. Hospitals, their model, the model is they can put on I can't.
Yeah.
What do we do as a group to help, you know, a lot of what's been done before is beneficial to primary care. We're not really sure what's help.
Yeah, first a comment about Massachusetts. When you look nationally, Massachusetts stacks up pretty well regarding cost of care because I think they just have more legislative kind of leverage in there, and certificate of needs kind of helped them kind of keep that reined in. So you look nationally, Massachusetts is kind of at the better end of that spectrum. You know, in terms of costs, you know, my perspective is the payers want us. They want the private independent practices out there because we're high value, low cost to them. They are killing, they're squeezing it. And eventually I think they need to recognize that they're going to suffocate us to the point that we just kind of end up having to get purchased and then they lose that leverage. So I think that's where the CIN can help have that conversation with the different payers. You know, because they really, I think they want us in the marketplace. Yeah. Yeah.
And that's the point, you asked about ophthalmology, where there are no providers. First, you can look at some of your are in the area, and we won't be replaced. And that's because medication has a payment much lower than the state. You know, and it's impossible. I mean, I've been in contact with payers in medical side. It's so cumbersome to get through them. Once you know what they are, they're no longer there. And then once they get contact, they don't pay you because they do things to say it's not part of the vision, it's just not. They just force you. That's what they're trying to say. I hear it.
Yeah.
Fine.
Yeah. Yeah, you're right. I mean, it's hard to get into their head, the payers, the commercial payers. You know, if you get to the right conversation, the right person, I think it can resonate that, hey, you want to keep us alive. Don't squeeze us on price. Yeah. Yeah. I mean, just as an example of, you know, private equity has stepped into this marketplace, and without drawing any kind of judgmental conclusions, their model increases the cost of care because they were able to consolidate and then have greater leverage against the commercial payers. Nothing wrong with that for the docs trying to maintain their independence, maintain value, but that's how they succeed. And that's, in my mind, that's also driving up the cost of care in the same way the hospital consolidations happen. So nothing necessarily wrong with the private equity marketplace, but I don't think the payers want to move in that direction because they find themselves on the receiving end of a larger negotiating entity. Yeah. 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 Any questions? Anyone online? Yeah.
Hi, Dr. Jackson. I just wanted to say thank you. You did a beautiful presentation. And I just wanted to make a comment about what you mentioned about the cost of care is a pre-planned by the payers and the non-profit. No matter what we do, unless as a PACN, our physician get united and provide the care at a lower cost, it's going to be difficult to compete with, as you mentioned about with the Wall Street ventures. I was just at one of them and they don't take a lot of insurance, including Medicare. So be prepared for the more out of cost payout for all senior citizens.
Yep, I hear you. I mean, it's a word about the nonprofits. It's interesting. They make up in the state of Pennsylvania about 87% of the hospital system in Pennsylvania are nonprofit. Look, nationally, it's around 60%. And yet we have board of directors who are representative of the, kind of the private sector, so to speak. So they understand the shareholder value, so to speak. But nonprofits, by definition, have no shareholders. Yes. You know, so who are the shareholders? Who are they working for necessarily? And I would position that they should be working for the citizens of that community. Those are the ultimate shareholders. Second shareholder, in my mind, is the business owners who are purchasing insurance products on the open market and the cost of insuring their employees within that. So I think those are two entities, two bodies that the board of directors need to pay attention. I think we have more physicians in there. They kind of understand that, and hopefully we'll be in a position to better negotiate that. Thank you all.
Thank you, Dr. Jackson. That was fantastic there. And I think it already generated some great questions. And again, some things that are unsolved there. The network is in its early stages. We do hope to achieve all of these things, but it's a long road. And as was said, the payers don't have it right. Medicare and the government doesn't have it right. We were just at a conference last week with the National Association of ACOs. CMS had a strong presence there, and they too understand that the specialists are not engaged as they should be. And they are looking at models to bring them into that. You know, the government rarely gets it right, especially right out of the gate, but it is a recognized need going forward. And again, I love the way Dr. Jackson brought it home that, you know, here in Pennsylvania, you know, we have the opportunity to lead and to change. So again, Dr. Jackson hit on it, but it was over a decade ago where we started to think about this in the medical society, and that Pennsylvania doctors needed to get in the game as it transitioned from volume to value and lead that transition. After that, the Practice Options Initiative was exactly for that, to maintain choice, to maintain the opportunity so that people did not feel that they needed to be consolidated into these larger systems, as Dr. Jackson pointed out, which have marginal benefit there and, of course, limit choice. And it not only benefits the independent physicians, but it benefits all physicians. So the physicians who are in an employed setting now have a choice. If there is a healthy and a happy economy for the private practice, those physicians have a choice next time the contract comes up for negotiation, is not necessarily have to swallow that. At the medical society, just again, organizationally, sometimes it helps. I'm a surgeon, so it's simpler for me to see pictures sometimes, but again, the network is down as part of this holding, or the CCC, or out of the medical society, which was the product of the Practice Options Initiative. Here's where we are. Again, it's just a representative, but those are the payers that we're involved with right now. We have 8 total, including the ACO, which is CMS. And again, we have about 60-something practices across the state, with over 125 docs and about 200 total physicians and providers in that. We've come a long way, and certainly we have a long way to go there, but we can take solace that many of the integrated networks that form never come to the productive phase that we're at right now. Again, this is not to rest any laurels, but just to acknowledge where we've come from. Our payer mix is here in terms of covered lives, got about over 68,000 total. That varies from month to month and week to week with beneficiaries in different plans. Results this year for 2022, again, overall, we continue to improve in Aetna, Capital, and Geisinger, as well, getting higher scores generally overall. And Highmark, we're now in the True Performance Plus program, and actually in the Northeast HIT shared savings in that for the first time. Wendy York is our Senior Director of Quality, and she's here tonight as well. Some of the other programs that are involved there, formerly known as Gateway, is Highmark Whole Care. Now that's the Medicaid population. Humana, who will be speaking with us a little bit later this evening, and UPMC as well out west. Wendy, I know this is a kind of jam full of a lot of information. Anything you want to highlight? Okay. We're, you know, our success is actually predicated on your success and the success of the network, and the great care that you give individually and collectively to all your patients every day. Here are some of the top performing practices in our network. Gladly, this list is increasing year on year. And again, continuous improvement is what we're all about, especially Wendy and our team. What does it result in? Well, this is the net distributions back to our practices, over $4 million since inception there. 2023 is still in progress there, but again, we're continuing the trend to do that. And this is just the start. We're on the cusp of much greater savings, especially as we get into shared opportunities with the payers as well as with CMS and the ACO. Here's a breakdown by the payer mix in terms of the different distributions, again, to that over 4 million. Highmark and Geisinger being the lion's share of that in the commercial market. 2022 was our first year in the ACO, and I knew it was going to be a learning experience, and indeed it was. We performed well quality-wise in that. We also saved, talking about savings, talking about U.S. healthcare and sustainability, we saved Medicare $2 million. It's laudable for a first-time ACO to do that. CMS has actually set the bar, though, just a little bit higher. We did appeal, and one of my conversations this morning was with CMS, having them look at it because we were very close to participating in that shared savings. Again, I knew it was going to be a learning experience. This brings me back to my days in the Bronx, drinking from a fire hydrant. I thought it was going to be on the right, but I ended up being well, you're left, and I ended up being on the right here. Completely overwhelmed with the knowledge. But again, we're in much better shape now to attack it. Here's some key points and activities that we're doing right now. I've highlighted the ones that you're going to hear a little bit more about there. This, again, Wendy's quality team is what's bringing this to your practices. Lisa Strom, Tracy Petrino, and Janelle Arthrell are the contact points and the names that you are most familiar with in that. But automating as much as you can in your workflow is going to help. And bringing patients in and getting a complete capture of them is going to be the key points that we're going to keep coming back to. When we look at our data, when we look at where we've done well and where we've almost done better, these are the areas of greatest reward that are just lie ahead of us. Annual wellness visits, again, getting the patients in early and yearly. CPT2 billing and comprehensive diagnosis codes in there. Pre-visit planning has a lot to do with that too. Shifting your workload to getting before the patient actually arrives there is one of the keys to success that we see over and over again in some of the more successful organizations. And as we hit maturity, we'll do that. This is going to be, a recurring theme. I think if there's one take-home message that we need to code properly or die. And again, as a physician and a surgeon, that's the last thing you want to hear is somebody telling you how to bill and the bureaucracy and everything else that goes along with it. But the reality is automation behind the scenes is what's going to get us recognized there. In a data-driven world, this is where the game is won or lost. And we shouldn't buy into it just because of billing, and we shouldn't buy into it even because of bureaucracy. In fact, I'm willing to fight against it for both those two reasons. But underlying it all is better patient care. When you completely capture a patient, and again, this is going to be across different platforms, across different specialties there. If you can get those codes in there, the patients are going to get more of the touch points and more of the care that they need and more of the recognition, no matter what the plan they're in. Be it in a commercial plan, Medicare Advantage, or in the ACO, if they are properly captured and fully captured, then CMS and everybody else knows, listen, this is somebody who's going to need some services and going to need some attention and is going to set aside the resources to do that. Without that, with just a simple code or not otherwise specified and all the other things, which I'm guilty of as all of you are, we're not going to get that. So again, our quality team does have some powerful tips and tools to help you with this and do it. Behind the scenes, we have some data partners that are actually driving our analytics, which will help us and are helping us bring to you the patients who need the most attention by these algorithms. Most importantly, they're identifying patients that are not coming to your office. You know the patients that come before you. You take good care of them. The ones that are not showing up, that have high risk and high conditions, are the ones that we need to make sure that we bring in. And those are ones, again, where we're going to really win big in terms of delivering better care and getting better recognition for it. Two other names. So without data behind it, Evoco and Brilliant Care, you may have heard those names before. Again, the group purchasing subcommittee, and a shout out to all the committees. I'll try to rattle through them a little bit later because we are a physician-led and run organization. They vetted each of our vendors their Evoco and Brilliant Care do help with remote patient monitoring and chronic care management. They can give you the tools to reach and to help care for these higher risk and increasing risk patients without overburdening your schedules, which are already taxed to there. So again, getting more care, more touch points, and again, hopefully avoiding those critical illnesses where they'll end up in the emergency room or in the hospital, unbeknownst to you and unbeknownst to us. I'm going to be up here a little bit later, so I can take questions for myself on, and I want to be respectful for the other speakers that are here too. One of our other partners that we've heard of before and a true friend of the network is Curi. Curi is a liability insurance company that does so much more, and they share our vision of helping doctors help their patients, and in the process, hopefully staying happy and healthy as physicians in that. Dr. Damian McHugh is the physician liaison for Curi. He's an ER doctor by training, and importantly, he is the chief at Curi helper that will get you to the right place with any Curi questions. Dr. McHugh.
Dr. Jackson, Mr. President, Dr. Pagan and Marty, thank you for this warm invite to your home. As John said, I'm an ER doc by trade. So Ted and I like to do things simply. We have lots of complex algorithms, ABC, airway, breathing, circulation, that helps us. In reviewing my sort of files to come and just share a few brief remarks, I was reminded of the ER doc way of public speaking, and it's show up, stand up, speak up, and shut up. And I'm going to do that fairly promptly and pass you off to a friend in a medical legal mind, Jason Newton. But truly, thank you for this invite for me to come and join you. Thank you for the partnership that we have. Curi is owned by 15,000 doctors. They are smart doctors. They are doctors that I work for daily, and they represent the same heart that you all have. Doctors that want to work for their patients. They're assisted by capable administrators. They look for solid leadership, but they want to get on with doing what's important, which is looking after patients. I've done lots of homework and preparation for my several visits to your state. And one thing that I read was there's a Pennsylvania Patient Safety Advocate Network, and they had some really, really nice pieces written about how healthcare is a complex, adaptive system. It evolves over time. And Dr. Jackson alluded to that in his very busy slide with all the various components of our healthcare system. What Curi realizes is that there really are two important things, and that's the doctor and the patient. And my whole company exists to serve the doctors that are doing the same good work that you're doing. I'm honored to be here. Pittsburgh is clearly filled with capable physicians. As an ER doc and a critical care interested person, I admired the work of Peter Safar in the museum at Pittsburgh, when in '61 he worked with the Pittsburgh anesthesiology team. He was the first person to make paramedics and ambulances. He was the first person to realize that when the heart or the lungs stop, we need to intervene with CPR and other things to get oxygenated blood to the brain. Simple discoveries, which now we look back and say, wow, but we've got lay people doing CPR in churches. It's wonderful. But your state is clearly filled with innovation and leadership. And as I said, I'm honored to be here. I have a colleague that is going to speak to you online and provide the medical legal input. Jason Newton is truly one of the best medical legal minds in the southeastern quarter of the United States. He was a trial attorney who practiced solidly for 14 years, defending doctors and hospitals. I'm thrilled that he came to Curi about 13 years ago. I have learned a ton from him since I came to the company 18 months ago, and I relish the continued opportunity to learn. It's time for me to to shut up. So I'll hand you over to Jason. I'm hoping, Keith, that with technology, you verified that he's online and we'll see his smiling face in a moment. Again, thank you to all of you. I applaud the hard work that you do.
Thank you, Damian, and thank you, Dr. Pagan. Thank you to Keith for having me again this year. I was with you about this time last year at your annual meeting, and Keith is going to be so kind as to advance the slides for me. So Keith, go ahead and I'll jump right in. My disclaimers are my standard disclaimers tonight. Hopefully what I'm sharing with you is going to be helpful. I'm not providing any legal advice. I'm not making any endorsements of any products or any candidates in any election. And any information that I share, I'm a lawyer for Curi. I'm Curi's in-house lawyer. I'm not your lawyer, so I'm here talking as your insurance company of choice and hopefully providing some helpful information. But just like you, I can't, you would do with your patients, I can't provide any guarantees about what I'm going to say will prevent a bad outcome or will mitigate a bad outcome. So with that out of the way, next slide, please, Keith. We talked last time a significant amount about our company's advocacy efforts, specifically in Pennsylvania. And I'm really here to talk to you tonight and give a little bit of an update on Pennsylvania venue reform. And for those of you who lived through the late 90s and early 2000s, at least, you can remember that venue reform came about due to a medical professional liability crisis in the Commonwealth. At that point, there was no real connection specifically to Philadelphia required in medical professional liability cases. That was the focus back then. And physicians from all over the state were being dragged in to defend themselves in med mal cases in Philly. From 1999 to 2001, the couple-year period before venue reform took hold, there were 87 $1 million and up verdicts in Philadelphia. Staggering. Some physicians in the state had six-figure insurance premiums. Maternity wards were closed. Operations were suspended because physicians refused to pay medical professional liability premiums. And then with venue reform, which was enacted by the legislature, a medical professional liability action could only be brought against a healthcare provider in the county in which the cause of action arose. What does that mean? It means where the care took place. And the effect was immediate. There was an exodus of med mal cases out of Philadelphia. In each of the 3 years before venue reform took hold, over 1,200 med mal cases were filed in Philadelphia. And that was on average. And then the year after venue reform took hold, there were 600 filed. So it cut that number in half, and then it decreased from there. So now, plaintiffs' lawyers are still looking to try to target physicians in Philadelphia, and they do have ways of bringing other physicians there. But why is it that plaintiffs' lawyers like Philadelphia these days? We talked about some old statistics. Next slide, please, Keith. Just some recent med mal verdicts there. You can read them for yourselves. The sticker shock really is the April 2023 case involving UPenn. In our industry, people try to come up with ways to describe large verdicts like these around the country. And some people describe them as aberrant verdicts. Some describe them as nuclear verdicts. But now with verdicts like the $183 million one, the pundits have felt that perhaps even the term nuclear is insufficient. And so there's a new term of art floating about thermonuclear verdicts. And that describes verdicts that are over $100 million, and that was certainly one. But, the key here is that plaintiffs' lawyers have been working to overturn venue reform for 20 years. Since that change was enacted in the early 2000s, plaintiffs' lawyers have been focused on judicial elections, on legislative elections. They've been working on composition of obscure rules committees that support the Supreme Court. And by the way, I do want to footnote, this is not Curi's data. This is data in the Commonwealth that doesn't involve Curi, and it's readily available in public. So next slide, please. So the path to rescission, it is quite shocking to believe that in August of 2022, the piece of paper on your right is what undid that 20 years worth of venue reform. The legislature was not involved. The folks who authored that document were the 7 justices of the Pennsylvania Supreme Court. And it was immediately understood when that was handed down in August to take effect January 1st, 2023. It was immediately understood that plaintiffs' lawyers would be funneling cases to Philadelphia and the likes of Allegheny County in Pennsylvania. Plaintiffs' lawyers were not shy about publicly admitting that if they had cases to file and the statute of limitations had not run or expired, then they would wait until after January 1st of 2023 to file them in a venue, a more favorable venue than they would have been able to in December of 2022. So this is kind of the landscape that existed around the time I spoke with you last year when everyone was predicting this increase in Philadelphia filings of med mal cases. And shortly after the Supreme Court issued this order, next slide, please, Keith, there's an organization called the American Tort Reform Association, or ATRA, and forgive the expression, but they put out an annual judicial hellhole list. That's what they call it. Pennsylvania certainly has been on the top 5 or 10 before, but as a result of the Supreme Court overturning venue reform, not only was Pennsylvania on the list, but it was specifically the Pennsylvania Supreme Court. They made top 2. And if you're not too familiar, I think you're probably understanding that Cook County, Illinois is not a great judicial environment, litigation environment. New York certainly is not. California is not. The surprise for you might be Georgia, but Georgia is emerging as one of the worst jurisdictions in the country as well. And so you're in company that is not too desirable to be within here with this rule change at the Supreme Court. So next slide, please. So what happened after that ruling came out? There was one more Hail Mary attempt before the fall election in 2022. It was a legislative attempt to, not rescind tort reform, to preserve tort reform. That failed, just like all the prior efforts did, and we talked about those last year. And then the next day, November 8th, there were the general elections, and the leadership in the House saw catastrophic losses, historic losses, and the result of the leadership change completely eliminated the chances that achieving venue reform was going to happen in the legislature. So what's happened since January 1st of 2023 when that rule change took effect? Next slide, please, Keith. So busy slide here, but it's just what was predicted, and I'll walk you through it a little bit. The chart over there on the right with the color graph illustrates that in Philadelphia, medical malpractice filings through July 31st, just over half a year, the number was at or it eclipsed the year-end totals for each of the years 2020, 2021, and 2022. And if you take a look at the month-by-month numbers, how many med mal cases were filed in January and February and March standalone, if you take 7 of the first 8 months of this year, the medical malpractice cases filed in Philadelphia exceeded that particular month's totals compared to any of the prior 6 years. On rough average, there are about 30% more cases filed each month than in any of the last 6 years. And the data proves the increases are related to the rescission of venue reform. And you can see that in the highlight there. 42% of all medical malpractice cases filed in Philadelphia through the end of July had care that took place outside the city of Philadelphia. In other words, those cases could not have been filed there in December 2022, but they could have been and were after January 1st, 2023. So that's the proof in the pudding that overturning venue reform is driving this significant uptick in filings in venues like Philadelphia. So what can you do? Next slide, please, Keith. Well, you can be an informed voter. Legislation, as I said, that's not going to fix this anytime soon. The next legislative election year is 2024, and that session will start 2025. In order to deal with this legislatively, it would have to be passed in 2 successive sessions, and then it would have to be ratified by voters in the Commonwealth. So we're a long way off from any judicial fix to this. There's no quick fix here. So the appellate court races in the state, and specifically the Pennsylvania Supreme Court race, is perhaps the next best option to eventually addressing this issue. We're looking at a matter of rebuilding the Pennsylvania Supreme Court with justices who are sympathetic to the hero healthcare providers in the state. And this is going to be a baby step process. There was a primary election for appellate judicial races in May, and there is a general election on November 7th. Put that on your calendar. Make sure you vote this year. And before you go, I understand that keeping track of what candidates you might be interested in supporting is a little bit of a daunting task when you get down the ballot, and average voters are not thinking about appellate judicial races. But there are competitive judicial appellate races, 1 seat on the Supreme Court, 2 on the Superior Court, 1 on the Commonwealth Court. And I'm not here to tell you who to vote for. I can't do that. But you need to be informed, and I can tell you that. Look to resources leading up to the election that you trust. One example I've listed out here, the Pennsylvania Coalition for Civil Justice Reform. This is an organization that PACN and Curi actively work with on advocacy in the state. This is an advocacy organization trying to reform the civil justice system in Pennsylvania. So look at an organization like that, and who are the candidates? Who are the judicial appellate candidates who opt to respond to election surveys that are put out by PCCJR? And then you can draw your own conclusions about candidates who took the time to do that for an organization like PCCJR, and you can read those surveys for yourself. All right, next slide. It's interesting, back in 2015, when the plaintiffs' lawyers were in the process of converting the Pennsylvania Supreme Court to a body that really favors their interest, Pennsylvania had the most expensive judicial election in U.S. history. I think the number was $15 million were spent on Pennsylvania Supreme Court judicial races that year, the most expensive in U.S. history. The experts, as you can see here, in May of 2023, were predicting that the high court race in Pennsylvania is yet again going to draw a flood of outside funding. What does that mean? It means that in addition to plaintiffs' lawyers within the Commonwealth, particularly given the national divisive and complicated political environment, people and special interest groups outside Pennsylvania are going to be sending significant dollars into appellate court races in the November general election. So it's important for in-state physicians like you all to make your voices heard with, at a minimum, showing up and voting and being educated about who you're going to vote for if medical professional liability is of significant interest to you in terms of how you decide to vote. I recognize there are many professional and personal issues that might dictate how you choose to vote, but please at least be informed on this particular issue. I also would recommend that you look for grassroots opportunities to get involved. I showed you this picture last time of our Camp Hill staff office from our staff there, and I couldn't resist again. Next slide, Keith. They were at a press conference related to attempts to preserve venue reform. Let's get more white coats involved in these types of opportunities. So look and raise your hand when they present themselves. What else can you do? You can consider liability limitations. Next slide, please, Keith. And I'm obviously giving you guys this deck, but what we worked with outside counsel in late 2022 to develop a venue consent reform. We considered all types of things in terms of arbitration or imposing limits on bad outcomes in terms of recoverable dollars. And we settled upon venue reform as the most likely to be upheld. It's still going to be contested by plaintiffs' lawyers and perhaps by the courts, but it's the most likely to be upheld. It costs you nothing. It costs those who are defending you next to nothing. And so why not restrict patients from suing you in venues that we know to be horrendous, like Allegheny, like Philadelphia? So what we've done is, the next slide, please, Keith. We've put together this venue consent form. And if you are interested in using it, you should incorporate this into documentation that's completed by the patient, that is annually recompleted and updated by the patient. you need to know that this will not apply. If it does hold up, it will not apply in all circumstances. For example, if the patient dies and then the family members who are the heirs are bringing a suit, it's likely that it would not apply. But in many cases, it could. The next slide, please. So what we've done is we put together an explanation in terms of why we are asking patients to sign the form, why you are asking patients to sign the form. Of course, you could modify this if you want, but we've come up with what we consider to be exemplary language. That's page 1. And then page 2 is next slide. And there you have it, the form. And what option you choose depends upon where your practice locations are. We're anticipating sending this out to all of our insureds via email within the next couple of weeks. We're really on the doorstep of having it complete. We sent out one previously, but we've gone and put more meat on the bone in case you have patients who have questions about this. And so what we'll be sending out, next slide, will also include talking points for your front desk if they get questions. And some practices have asked us, well, if patients refuse to sign this, can we terminate them from the practice? And the answer is you can, assuming you file the normal rules. And so I've just put in here a reminder about the termination toolkit specific to Pennsylvania that Curi has put together. We're not necessarily advising that, but for folks who are interested in going that route, we wanted to provide support and resources. So what else can you do? Next slide, please. Protect yourself, protect your assets. If you, the standard generally speaking is that if you know about a claim that is being made against you, or if you should know about a claim or lawsuit that's being made against you, it's too late to do any asset protection. The analogy I use a lot of times is you cannot buy insurance. You can't buy an insurance policy on a house that's already on fire. And so I can't emphasize enough to you to get help on your personal asset protection strategies. I've got a QR code there in case you want to take an image of that and follow the link. It's to a blog post by our colleagues within Curi Capital on just this topic. Frances Cronland is the author of that. She works at Curi Capital and is happy to engage with anybody who's interested in making sure that you have your assets locked down and protected as much as possible before, heaven forbid, you get named in a claim or a suit that involves medical malpractice or frankly anything else. If you are in an auto accident or someone is injured on your property, asset protection is going to help you in all those different types of scenarios. The next and final slide for me here is just an example of a doctor who allegedly tried to move her assets too late. What the fact pattern here is that in Washington State, there was a $13 million verdict against a doctor in a medical malpractice case. That verdict amount exceeded her available insurance coverage. And then after, the plaintiff is trying to make claims against the doctor personally to recover her assets. And the plaintiff is alleging that the doctor pursued asset protection transfers after being on notice of patients' threats to sue that were posted on Yelp. So therefore, the patient and the plaintiff in the med mal action files another suit alleging that the doctor intended to defraud future judgment creditors. That's the plaintiff with a $13 million judgment against the doctor. The doctor's attorney says, there's two sides to every story. These were part of a comprehensive estate planning strategy unrelated to any pending litigation at the time. The problem I see there, not knowing anything about the case except the headline in the article, is that the doctor's attorney is referring to pending litigation. And again, it's going to be tough slogging if you are being sued and you're trying to conduct asset protection in that type of posture. So the suit there continues. So that's the comments I had for you prepared today. If anybody has any questions, I'll be happy to field them. And I thank you for your patience and let me walk through that.
Okay, yep, we could do that. And at the same time, Jason, I don't want to catch you off guard, but one of the questions I had, and one of the things obviously all of you could do and should do is, again, you already have your membership in the PA Clinical Network. Your membership in the Medical Society is assumed. That gets you a lot of discounts in our network there. So joining PA Med and continuing that advocacy, but also PACN our political action committee, does the same vetting of candidates, does the same interviews of the judges, and will let you know specifically in your district or in your region of the state who are physician and patient-friendly candidates and who are not. So I encourage you also, that's one of the other actions that you could do. Jason, I think last week there was a Superior Court decision in Pennsylvania that had to do with a much more strict interpretation. Dr. McHugh mentioned the valuable work that the Patient Safety Authority had brought forth, and that was part of the MCARE Act and part of back 20 years ago in 2002, what we got out of that. And my understanding that the Superior Court ruled that a very, very narrow amount of information is protected from disclosure in a court series, whereas before it was generally said that if there was a bad outcome and there was some root cause analysis done, you know, with the patient safety officer in your hospital, looking to try to figure out what you can do better and what you can improve. And indeed, that's what we're all about here. We're about quality. We're about improving care in doing that. But I understand that at least the way the Superior Court looked at it, it almost gutted that and eliminated that disclosure protection.
Yeah, that's not surprising, Dr. Gunn. If my general rule of thumb is that anytime, particularly an appellate court, gets an opportunity to revisit peer review or quality review protection, they sort of forget about the purpose. And that is that the reason those things are set up is not to shield information from litigation, but to improve care and improve. And yet they can't resist themselves. And so they scrutinize the process. And if it doesn't follow the letter of the law, or if there's ambiguity in definitions of who's involved, then they are generally speaking inclined to not grant that protection. There was a monumental ruling a number of years ago in Pennsylvania as well. It's not only happening there, I'd say that's a general, maybe trend is too strong a descriptor, but we see that around the country for sure.
Thank you.
It's unfortunate.
This is Dr. Silver.
Having a fundraiser for the Republican next week, that was that tomorrow. It's going to be possible for you to vote for somebody who's going to put the tax to the fundraiser next week. The question is, are we cultivating judges who are not on the Democratic side, who are with us, and you know, we need to see that because we're going to if there's an election coming up, it's going to get worse.
So both Jason and those that are logged online, and I'm going to try to rephrase because again, the room mics are not on and this mic is, talked about the polarization in politics these days. And Jason, I think, as you said, you know, if tort reform and if venue reform are one of your key issues, you know, there are candidates to look at. If there are other issues, and again, physicians being very socially conscious are aware of a number of issues that you may not get the same candidates that are supporting what you believe in socially at the same time that what you're believing legally there. And the climate, I guess, seems to be dividing rather than coming together. I know it's a very astute observation. I don't know, Jason, if you have any comments or cures for that.
I generally don't touch that with a 10-foot pole. And that's why it is very astute. And physicians have difficult choices to make. And that's why I don't endorse. I said it from the beginning. I don't endorse any candidates, can't tell you how to vote, but I can tell you to be informed so that you can follow your personal and or professional compass. And when you walk into the voting booth, you're not just blindly checking boxes, but you've made the decision in advance about how you want to vote and what's important to you.
Right. I think that awareness is key. And I think that's something Dr. Jackson probably throughout his year as president has been saying. I know Marty also has been saying that, you know, with these issues and these candidates, probably the only candidate that's going to vote 100% the way you would is the one looking in the mirror. Other than that, you know, it's going to be a mixed bag. They're going to vote some ways in some issues and some ways in others. You just need to be educated as which way and your important issues on that. But again, you can see one of the common themes is in our partners and again, with the friends of the PA Clinical Network, they do have our common mission and our common goals at heart. You know, everybody that you hear from this evening, everybody that our subcommittees vet, you know, are looking for the common mission of helping our doctors work smarter and not harder, and also at the same time helping us get full recognition and a healthy, happy practice and get full reward for that. You'll see this placeholder every now and then. Again, it's their take-home message, and one of the important things that you're learning tonight. Our quality team will continue to provide you with tips and highlights to your workflows, and most importantly, to optimize your EMRs to capture the good work that you're doing in your straightforward and in your more complex patients. Another important automation is lab data and getting lab data into our records. Next, we're going to hear from another one of our PACN partners and friends who is dedicated to our mutual success. Brooke Arevalo is the Regional Director of LabCorp for Pennsylvania. Brooke? Did I say it right?
You got it.
All right,
I'm so
all right.
proud of you. Hi, everyone. Good evening. My name is Brooke Arevalo, and I am, as Dr. Pagan said, the Regional Manager at LabCorp. And although I don't have an MD after my name, I am working towards an MBA, so rest assured. I'm here with my colleague, Jack Muller, and we are really pleased to be here, Dr. Pagan and Keith. Thank you for having us here to further our existing relationship with PACN. I'm going backwards. Oh, here we go. So when we look at LabCorp's mission to improve health and improve lives, as well as our strategy to deliver world-class diagnostic solutions, bring innovations in medicine to patients faster, and use technology to improve that delivery of care, it's really in line with PACN's mission of collaborative action, championing independent physicians and superior results. And as Dr. Jackson so eloquently relayed, healthcare is changing at a rapid clip. I don't have to tell you guys that. And the introduction of the value-based care model has shifted the mindset from quantity to the quality of treatment. So when we look at who is LabCorp, and I'm so proud to say this, we are the leading global life science company, we are the largest lab in the world. And what does that mean for you guys? That gives you access to our over 5,000 test list. We continue to leverage technology to improve care delivery and bring innovative medicines to patients faster. As that bottom piece lists, we support clinical trials in nearly 100 countries and have worked in developing nearly all of the top pharmaceutical drugs on the market. So it's really, I used to sell pharmaceuticals, and it's so powerful to me that we can broaden the opportunity to enroll people who don't look like us and might be suffering from disease states that they never would have had access to clinical trials to in the past. Again, LabCorp Diagnostics, we have over 40,000 global staff, 160 million patient encounters per year. We draw on average of 3 million plus samples processed daily. Jack and I have had the privilege to go to the lab at 3 o'clock in the morning, and it is like Santa's workshop. It's incredible to see what happens behind the scenes. Now to the fun stuff, data analytics. Data really is the new currency. LabCorp has established a live data feed between Health EC and PACN. And really, what does that mean for you all? When utilizing LabCorp, the data feed offers a line of sight to all of your attributed patients. And I think you touched on this, Dr. Pagan, but not only to those patients that you see every day, but more importantly, to the patients that are rising at risk to help you close those gaps in care. So in essence, using LabCorp affords your staff and you one less piece of data that your team has to chase down manually and get that patient into the office sooner to avoid any life-altering events for them. Here's the letter that was released back in April of 2022, and I just highlighted some of the points. Again, we are looking to be your partner to improve patient care while providing more cost-efficient services. I know as well as you guys do that we are up against a hospital-dominated market. It is hard to fight against the big guys, so we do our best to continue to provide cost-efficient services and provide best-in-class diagnostic testing. That says over 4,700 tests, but we're up to over 5,000. We do offer a dedicated support team, Jack Muller and myself. We also have Carla Smith, who's up in the Poconos. So you do have a direct line. Whenever you have any questions, we're here to support. We have a robust specimen tracking and courier service, and we have over 126 patient service centers throughout Pennsylvania. And I would love to grow that market and offer more access points to your patients and you. Happy to announce, as of July 15th, LabCorp is now fully in network with Capital Blue Cross Blue Shield. That used to be a real barrier to Jack and me to offer your patients and you better service, because if a provider was using one lab and we'd come in and say, use LabCorp as well, the challenge would be they'd now have to use two labs. So with us being in network with Capital Blue Cross Blue Shield, we've removed that barrier. And if you look, as I mentioned, our infrastructure, these are the specific counties that Jack and I cover. As I mentioned, we're always trying to add patient service centers to this list to provide additional access points. Thank you.
Thanks, Brooke. That was short and sweet. I don't know, any questions for Brooke or LabCorp? Yeah, I guess and again, I didn't get it, so I'll try to repeat too. The question was regarding the western part of the state and Allegheny and the presence of LabCorp. And I said, I think I heard yeah, UPMC. Okay, not in network with UPMC. And I guess if you're LabCorp, you say yet. Okay. There again, our take-home theme tonight. Our teams are going to reach out to make sure your EMR and your workflows are optimized to make sure that this your coding is simplified. I did say before I was going to call out and recognize again as a physician-run organization some of our key committees. Our quality committee is chaired by Dr. Bartolomucci. Our oversight and group purchasing is chaired by Dr. Armstrong, who is here. There, thank you. Contracting by Dr. Ramanian, funds flow by Dr. Wirtz. Our ACO oversight board, again, the physicians that serve on that, as well as our PACN board, and our credentialing, which is chaired by Dr. Ramanian as well. One of our growing Medicare Advantage partners for the PA Clinical Network and one of our more innovative payers is Humana. We do have the privilege tonight of Dr. Robert Zorowitz, who will share updates from Humana and their mutual commitment to helping keeping doctors healthy and happy as they deliver great care to Humana and all members. Dr. Zorowitz, do we have you? You may be muted, sir.
Now, can you hear me?
Yes, we can. Thank you.
Terrific. That's important. So good evening, everyone. On behalf of myself and Humana, it is a real honor and a privilege to have the opportunity to address you, the PA Clinical Network. So I am Bob Zorowitz. I'm Regional Vice President for Health Services for the Northeast region of Humana. And just by means of background, I am a physician. I'm an internist with boards in geriatrics and hospice palliative care. And I actually spent a good deal of my career treating patients in the hospital, in the office, hospice, and particularly nursing home for many years. We oversee all clinical activities as well as that nasty utilization management for our clinical partners in the Northeast. I wish I could have been with you in person, but I'm actually at a meeting in Washington, D.C., learning how to pronounce the word dysfunction. And not to worry, I promise not to bombard you with a lot of data this evening. So, although the percentages of physicians and other healthcare providers in independent practices is shrinking, Humana has always been in the forefront of support for these practices. We think you're important. And when I think about the plight of independent physicians in the era of growing hospital systems, private equity, insurers gobbling up practices, I can't help but conjure up in my mind that first scene from Raiders of the Lost Ark. Can I have the next slide, please? South America, 1936. Indiana Jones braves poison darts, tarantulas, darkness, and other traps to retrieve the prized golden head. And just when he thinks he has it, the cave starts collapsing. He barely gets through the closing cave gate and a giant rolling ball just to find dozens of poison spears and arrows aimed at him. And oh yeah, then there's the Nazi villain. Okay. So why, as a recent New York Times article writes, are multi-billion-dollar corporations, particularly giant insurers, gobbling up primary care practices? Now, full disclosure, Humana has established approximately 250 CenterWell senior-focused primary care practices around the country, although none in the Northeast, and I don't have any relationship to them, though I do work for Humana. And I also know that you have more than just primary care, and you have very important specialists as well in the clinical network. So I do recognize that. But according to this New York Times article, the appeal is simple. Despite their lowly status, and by the way, I would argue that primary care practices are hardly lowly. I think they are noble and the linchpin of the healthcare system. But primary care doctors oversee vast numbers of patients who bring business and profits to a hospital system, a health insurer, or a pharmacy outfit eyeing expansion. And we haven't even mentioned the role of private equity in buying up not only primary care practices, but specialty practices, ambulatory surgical centers, et cetera, et cetera. According to an Avalier report on physician trends, 73.9% of physicians in the US were employed by the start of 2022, of which 52.1% were employed by hospitals or health systems and 21.8% by other corporate entities such as private equity firms or health insurers. No doubt these numbers are probably larger now. Now, I would presume that most of you have steadfastly remained independent because you want to maintain your autonomy, which not only includes how you run your practices, but equally, if not more important, doing the right thing for your patients. But doing the right thing for your patients has become increasingly complex. There are disease management guidelines, preventive management guidelines, documentation guidelines, CPT, ICD-10, and we're having repeated emphasis on coding and documentation, which I agree is really the lifeblood of revenue for not only practices involved in value-based care, but payers as well. And not to mention the increasing complexity of older adults with multiple comorbidities and polypharmacy. And then there's that pesky EMR and more and more and more technology. Now, we do recognize that Humana members may comprise just a small fraction of your patients. We saw that in one of the earlier slides. But we would still like to support you and grow with you. And I think you will find that what is important for your patients clinically is important to us too. This certainly includes access to clinically necessary services, equity, and individually tailored approaches to wellness and to management of chronic conditions. And in short, I think it is fair to say that what patients, practices, and payers share in common is the expectation of high-value care. Now, when we speak of high-value care, we are really talking about developing those relationships with patients and providing evidence-based clinical care as cost-effectively as possible. One way of unpacking this concept is by examining the triple aim, which many of you may be familiar with. If you can go to the next slide, please. Thank you. The triple aim has almost become a mantra or a cliche, but it's three goals: better health, better patient experience, lower per capita cost. Here represented by the IHA triple aim of population health, experience of care, and per capita cost. Now notice, population health refers to the whole panel of patients. Experience of care is the experience of individual patients. It's kind of a juggling act, managing a population, managing the individual. So the three costs, better health, better patient experience, lower per capita cost, really do have meaning and represent the three legs of value-based care. Yet, with the pressure on physicians and other providers, increasing burnout, structural inequities in the health system, and the race to keep up with technology, many practices even are starting to envision a fourth aim. If you can go to the next slide. So here's a schematic showing the possibilities of a fourth aim. Now, the Institute for Healthcare Improvement, IHI, has sort of batted back and forth what that fourth aim might be, but note that provider experience, or the joy of practice, is proposed on equal footing with the other aims. I would suggest that when the goals and stakeholders are aligned, patient, practice, payer, with the necessary resources, organizational structure, infrastructure, technology, and equally, if not more important, the time, the joy of practice becomes a realistic objective. Now go to the next slide. Now here, you may be less familiar with this. Here are the 5 M's of the age-friendly health system or practice. Now, I know that many of you may not focus on older adults. Many of you may be pediatricians, and many of you just may have not a focus on this population. But I especially admire those of you who have the skills to treat a wide range of ages, including older adults. As a geriatrician myself, representing a provider of Medicare Advantage plans, I admittedly do have somewhat of a bias towards these benchmarks of excellence in the care of older adults. While the quadruple aim is as much about the population as the individual patient, the 5 M's are really about the individual patient. And I don't believe any of this is mutually exclusive. Now, just take a quick look at this. You'll notice that mind, mobility, multi-complexity medications, but that 5th M, what matters most? That's really I think that's the core. What is important to the patient? And what that requires is time and listening and really being able to get to the heart of the matter. What is really important to that individual? At the same time, you're balancing and managing a population. This is not easy. And I don't believe any of this is mutually exclusive. So I want to show you a more fully formed quadruple aim in the next slide. I hope you see that, you'll see that what it has integrated is the triple aim, the added 4th aim, and the 5 M's into a unified whole. Not easy to accomplish, but very much doable. And you'll notice, very importantly, I put in red the additions that are important to, I think, enhancing the quadruple aim. And if you look at the bottom right, provider experience, provider satisfaction, work-life balance, workflow optimization equals joy in work. I think that this is a unified whole. And again, as I mentioned, it's not easy to accomplish, but very much doable. What is key and has never changed is that this is all about the relationship between clinician and patient. I think that we would agree that this starts with a comprehensive assessment, at least yearly, with a review of the status of chronic conditions, identification of risks for other conditions, and an individually tailored plan of care, including both treatment of current conditions and preventive interventions to allow for early identification or prevention of other common conditions, with emphasis on what matters most to the patient. And I guess I need to mention coding and documentation since that seems to be a recurrent theme. I'm sure I would be remiss and if I did not mention that once again. So for older adults, the Welcome to Medicare exam or the subsequent annual wellness exams are designed to facilitate not only a comprehensive assessment of clinical conditions, but to also screen for common conditions, depression, dementia, and even social determinants. Now, you knew there would be some sort of plug here, right? And we had mentioned annual wellness visits, and thanks very much to Dr. Pagan for having mentioned them before, because I think this really gets to the heart of the matter. I'm sure I don't need to go over the components of the Medicare wellness exam, but in case you are not familiar with these services and the G codes required to report them, if you can go to the next slide. This is just a brief review of the three types it's the two types of Medicare wellness exams. And on the right, you see the routine physical exam, which is more the traditional history and physical. And I should just mention that Humana, and maybe other payers as well, we not only pay for the Welcome to Medicare visit, the so-called Initial Preventive Physical Exam, or IPPE, on the left, the annual wellness visits, the initial and subsequent, but we also will pay for those routine physical exams. So I promise I'm not going to get into the weeds this evening, but at the bottom of that page is a link, and that will provide you all the information you need that shows all the components of the wellness exams. And it's a publication by CMS that's available on the internet. We have found that when done properly, practices with higher percentage of patients who have received these services tend to have fewer hospitalizations, fewer ED visits, higher HEDIS star scores, and more thorough and accurate coding. There again, I'm mentioning it again because I have to, which of course equals higher revenue, but I think the fewer hospitalizations, fewer ED visits, higher HEDIS stars, and better patient experience are really the key here. At Humana, we examine this type of data regularly and share it with our contracted practices. And more, we want to assist practices in performing and perfecting population health, that is, applying sound evidence-based approaches to maintaining and improving the health of the panel of patients, whether in the exam room or outside the office. This too requires data, and we are more than happy to share it with practices. We also understand that it isn't always easy to develop the infrastructure, organization, or IT to do these exams efficiently. But anecdotally, we have found that practices that organize around not only providing these services, but around the quadruple aim, and when caring for older adults, the 5 M's, tend to have both more satisfied patients and clinicians, both. And we are committed not only to have more satisfied patients, but we like to have happy clinicians as well. None of this is easy, but while many physicians have become disillusioned with medicine, we still think it's possible to have a positive experience practicing medicine and even find joy in it. So we appreciate everything you do, not only for Humana members, but all of your patients, and thank you very much for your attention. And with that, we can go to the next slide, and I will take any questions. If there are any questions, I cannot hear them.
No, I think you answered them all, Dr. Zorowitz.
I can't be that good.
No, I think, you know, I think we've had a full agenda. We've gone through a lot. Oh yeah, please.
Can you hear me?
Good. I'll repeat it. Yeah, okay. Great.
I'm an ophthalmologist. Can you hear me?
I can hear you.
What's happening right now in ophthalmology, and I don't actually do cataract surgery. I do pediatric ophthalmology, which is strabismus, nasolacrimal, and adult and pediatric oculoplastics, which is eyelid surgery. And there's this push right now to in-office surgery. And there's a company that's pushing it very strongly and basically getting centers, put together and then, getting a different tax ID and then going to insurers like you and saying, hey, will you pay us? And then taking a cut in this. And that's great, except, it would be nice if insurers like you were proactive. And if I'm doing procedures in the office, the additional, 10% or 15% that Medicare pays for me to do a blepharoplasty in the office doesn't really cover my costs. It'd be really nice if proactively, those of us who do procedures in our office, which save you money, could have some benefit from that and be paid a little bit more, as opposed to doing in the hospital or surgery centers. And I don't know if you have any thoughts on that.
Well, we do have a lot of resources that are focused on trying to transfer from hospital-based procedures to outpatient-based procedures. So that's actually fairly consistent with the philosophy of us, and I'm sure other payers as well. What you get paid, of course, is based on whatever the contract is. I'm not particularly familiar with that area of medicine, and I could certainly get back to you on that if you would like. I would just need your contact information. My email is on the slide, and if you just want to email me, with a little detail, I would be happy to get back to you on that.
Well, again, thank you, Dr. Zorowitz, and again, I appreciate the recurring themes that we have going through there: working smarter, not harder, keeping healthy in the process as physicians, and again, the importance of the coding and the take-home message that we've got there. All of our success hinges on that. I need to recognize the small but mighty team behind the PA Clinical Network, not only for the great work that they helped you do to date, but also because they will continue to be reaching out to you in the weeks to come. Here with us tonight is Wendy York, Senior Director for Quality, Bruce Rocher, our Chief Financial and Operating Officer, Keith Taylor, Senior Director for Business Development, Lisa Strom, Director for Quality, and also in the background, Shelley Scovens, our Director for Data Analytics, who you'll definitely been hearing from to help some integration, some of our new tools and smart analytics in the background. Tracy Petrino, Director of Quality, and Janelle Arthrell, again, one of our quality consultants. Donna Banks is our Executive Assistant who keeps us all honest and straight there too. So your questions and comments may funnel in through her as well. As we enter the last quarter of this performance year, we're on the verge of greater recognition than we've ever had before. And because illness does not follow a clock or an arbitrary calendar date of New Year's Eve, what we achieve now and tomorrow carries forward into 2024 and beyond. This is a long game. It's multi-year. Each year builds upon the prior for durable success to allow us to innovate and to allow PACN to lead, just like the vision of the medical society. Avail yourselves of our partners that can, again, help you work smarter and reap increased revenues in the process. Your feedback is important. You have a survey available for this. Emails and texts and reminders will be going out. Look for us on our homepage as well. And again, if there's any questions that weren't answered or that you think of after the meeting, please let us know. Together we are stronger. Together we can achieve higher success and lead Pennsylvania and the nation in delivering better care and not killing ourselves in the process. Again, the website is there to learn more, and you can also find your specific practice and your tiering, ranking, and care gaps. And for those of us who are socially adept, please make sure you keep us in front in your social media and comment when needed. That brings us to the end of the evening. close to being on time too, which is heroic for a physician organization.